The commonest question that I hear in my chamber for the last 26 years of my surgical practice is, Doctor साहब कोई risk नहीं है तो? Now it has always bothered me that how to answer this. There are several questions which come up after the surgery too. So today we are going to discuss that the questions that come to your mind when you're going for gallbladder surgery. Hello there, I am Dr. Purnendu. I am a surgeon in Genesis Hospital, Kolkata, and today we are going to discuss all the questions that I have gathered from my patients before and after they have had a gallstone surgery. Talking about the risk factor, every procedure has its inherent risk. I was talking to one of the patients, like, do you feel scared when you come out of the house or when you are returning home? And the patient said, why should I? Then I tried to give the statistics. The national statistics is every hour 16 people die from road traffic accident, and it is yearly 1,35,000 death and 5 lakh people seriously injured, and it's the 5th highest cause of death in the world. But still nobody feels scared when you go out. Nobody feels scared while traveling in the street. So like that, every surgery has its inherent risk. The risk for gallbladder surgery or laparoscopic surgery could be injury, bleeding, infections, and post-operative certain digestive problems. But they are percentage wise, it is 0.1 to about 2%. So which means in 1000 patients, 1% will probably have its complications. So 999 people probably will be fine. So this is a thing that we give reassurance to the patient. So I tried to understand that what is it that caused the fear? Is it the fear of death, fear of pain, fear of anesthesia? So I think when we address all these aspects to the patient, trying to tell them, look here, that anesthesia is so safe now that the moment surgery is over, the patient actually recovers on the table and the patient is able to communicate with us and obey commands. So one of my professors jokingly used to say, when we put the last stitch, after that patient should be able to say thank you, that's perfect anesthesia. What about pain? Pain is something which can be taken care of. The operation is done under general anesthesia, so you don't understand any pain or anything what's happening. And in the post-operative period, every pain can be taken care of. The next most common thing that I hear is, Dr. Saab, do I have to get the operation done immediately or can I wait? And they all have excuses like next month my friend's wedding or I have booked a ticket to Kashmir. Now the answer to that in a realistic way is, it is not an emergency just because you have been diagnosed as gallstone. There is a possibility that the patient can be perfectly normal for the next 2 years, and there is a possibility that tonight a stone can slip out of the gallbladder, go into the bile duct and cause obstructive jaundice or pancreatitis, and it can get stuck near the neck and cause severe pain and infection, which means all the possible complications. So what we try and convince the patient is, or the answer to this question should be, the earlier the better. No one waits with a disease awaiting when trouble will start, because most patients say, मेरे तो कोई तकलीफ ही नहीं है, I don't have any problem, why should I have the surgery now? You don't have the surgery because there is pain. You have the surgery because gallstone can give potentially many risky complications. Next worry is anesthesia. Doctor, is this going to be full anesthesia or local? Now, laparoscopic surgery or cholecystectomy is usually most of the time done under general anesthesia, where a person is put to sleep completely and the person do not know anything. As far as the anesthesia which is partial spinal, the operations which are done below the navel, something like cesarean section, hysterectomy, ovarian cyst, or hernia in the groin, or any surgery in the lower limb, in the knee or ankle, they can be done by giving a needle in the spine, and that is called spinal or epidural anesthesia. Certain small operations can be done under local anesthesia by giving injection and making that area numb. But to remove the gallbladder from inside the abdomen, whether laparoscopically or after cutting open the tummy, it's usually preferred that it has to be done under general anesthesia. The risk is about, Dr. Saab, when will the person gain consciousness? Gone are the days when people used to anesthetize with ether and they didn't have control. Sometimes you do the surgery in the morning and in the evening patient is still coming out of the drowsiness. Now you induce, which means you put the person to sleep, and we give reversal that the patient obeys command the moment the surgery is done. Preparations or instructions that are given to the patient when they are coming for the surgery. Usually we always tell that the patient has to come in empty stomach, nothing to eat in the morning. They can have their early light dinner by 8 or 9 o'clock, and next morning not even tea, water. In fact, I still remember one patient, I said, don't even drink tea or water. So this particular patient came and said, you told me not to drink tea or water, so I drank one glass of orange juice and came. Now please try and understand that why we want the stomach to be empty, because when we give anesthesia, if the patient vomits with a full stomach, because under anesthesia they can aspirate and it can go into the lungs. So the patients coming for surgery has to be completely in empty stomach, not even drinking sip of water. As far as the medications are concerned, this is extremely important. If the patient is on any blood thinners, which means any medicines which are antiplatelets, which they are taking for coronary artery disease, they have to stop that for 5 to 7 days before surgery, because the blood thinners won't allow the blood to clot. Now, if they don't tell that to the doctor and they continue it, at the time of surgery it will start bleeding because the blood will not clot. Talking about other medications, there are times when patients have this feeling that I'm going for surgery and they tend to stop most of the medication. If the person is on antihypertensive for the blood pressure, if the person is diabetic or hypothyroid and taking L-toxin tablets, they need to continue till the time, that is the night before the surgery. Now next morning, if the person is on antithyroid, they should take the medicine with a sip of water, not a glass of water, because thyroid status, and if they're on antihypertensive blood pressure medicine, they should consume that. They should not consume the diabetic medicine because they are going to starve that day. So if they take the anti-diabetic medicine, the sugar may drop to very low level. Many times we ask the patient to take a laxative the night before, because at the time of surgery early in the morning, if the bowel is clear, then it's easier. The doctor would have asked to get the routine pre-operative tests like hemoglobin, TC/DC, blood sugar, blood urea, creatinine, liver function test and extra chest ECG, or if there is any other problem, the routine pre-operative which are required by the anesthetist for anesthesia, and then the person is taken up for surgery. After the surgery, when the surgery is over, the patient is being taken back to the post-operative ward. Many of the patient's relative is very nervous why their patient is not talking, Has he got the sensation or consciousness back? Now the patient is under the influence of anesthesia, but they can hear and obey commands like you ask them to show your tongue, protrude your tongue out, and they will do it. So that means they're able to, but they're a little drowsy, and it is better that way because they can sleep the post-operative period. The person may have a little nauseous tendency. Some people can vomit after the surgery. This is the effect of the anesthesia. And some people may complain that they are getting a lot of pain. One of the ways to reduce the post-operative pain is we give local anesthetic injection at the site of making the port. So where we have made the incisions, you give local anesthesia. So that anesthesia action lasts for some time, and the post-operative painkiller dose requirement is much low. You will be having an intravenous line, and that is a drip, because in the immediate post-operative period, because of the nausea, we can't let you have food or drink directly. So maybe sometimes 12 to 24 hours, there will be intravenous fluid of normal saline and dextrose. The medications are given for the first 24 hours through the intravenous line. You may have a drain coming out, a small pipe coming out from your tummy, because after the surgery, when we have washed that area and cleaned it, this wash fluid can come out and collect in a bag. If it has been a very difficult surgery, and if the bowel or the gut was all stuck and adherent, sometimes we put in a Ryle's tube through the nose and to suck the gastric content out to give rest to the patient's intestine. You're usually discharged within 24 to 48 hours after the surgery. The doctor will prescribe you the medications which you need to follow when you go home. There are certain do's and don'ts which are instructed by a manual or a booklet to you. Somehow another thing I have noticed, that many of the patients are very surprised that why do they have pain. Now in laparoscopic surgery, 4 rods or tubes have been put inside the tummy and the gallbladder taken out. Even when you pierce your ear with a fine small needle, that also pains. If you take an injection in your arm, that pains for a few days. Here the pain will be there, but a follow-up painkiller will be advised. And sometimes a little hot water bag applied to the area of the surgery can relieve little bit of pain. Second common complaint that we hear is there is a bowel disturbance. A large number of people complain of constipation, and some people later on will complain about diarrhea, increased number of bowel movements, sometimes going up to 4 to 6 watery bowel movements, which may last in 10 to 20% of the cholecystectomy patients even after years. Constipation is one thing which has to be taken care immediately post-operative period. It's like this is a bowel habit which one is used to in your own home, in your own washroom. So many times we have noticed a change of place in the hospital. If you haven't had bowel movement, then you are scared, frightened to go to the washroom. But that's the reason why laxative is given routinely to most post-operative patients. And you should not wait for 4-5 days when the stool gets hardened up and it comes out, and with causing tear in the anal area, causing bleeding or severe pain. What is important is that the step should be taken before it reaches to that level, because I get only phone calls from my patient, डॉक्टर साहब आप 5 दिन पहले ऑपरेशन किया, I still haven't passed stools. Don't wait for 5 days. There has been no phenomenal recent advances in treatment of constipations. It's been the same for the last 100, 200 years. You yourself will have to take the laxative and pass stools. No one else can help you pass the stools. It can't be done by remote control or Wi-Fi or laser or something like that. You're allowed to take a walk, climb the stairs, and do small little activities to start off with. One restriction, that is, you should not lift heavy weight. What it also means, you should not indulge in any activity which cause strain on the tummy. If you're a smoker and you have smoker's cough, try to avoid smoking or coughing because it will hurt the tummy. So if you do get a cough, don't allow the pressure to build up. If you have a pillow close by, just take the pillow and just hold it and then cough. Otherwise, if you don't get a pillow, just put your both hands on your tummy so that the pressure doesn't come on the stitch lines. As far as the diarrhea is concerned or increased bowel movement after gallbladder surgery, about 10 to 20% of the people sometimes continue to suffer with this. And some cases where it is very severe, the patient says the moment I eat something, I get this urge to go to the washroom. It's something like a very irritable bowel syndrome. It starts. Now, all studies and investigation has tried to find out the cause for it. It is the increased bile acid which gets into the colon which causes this diarrhea, and the medicine cholestyramine which binds the bile acid has been seen to reduce this increased bowel movement. As far as the post-operative period diet is concerned, a lot of people tend to become very obsessed and said that now that my gallbladder is gone, should I be eating only boiled vegetables and all that? One really doesn't have to be that cautious. It's a normal type of food that people are eating at home, but some people who are not able to tolerate, they should not have very heavy, oily or fatty food to avoid fat contents, because bile is sometimes necessary for the digestions of fatty food. One can get low-grade fever in the post-operative period, but if the fever continue or persist, then one should consider that there is a possibility of an infection, either a lung infection or the infection in the operating site or in the scar or the wound. So if the fever is persisting, you should always get in touch with the doctor immediately. There is another possibility is about discharge from the area of the scar. If it is open surgery from the scar line or redness around the stitch line, and if it is laparoscopic surgery, any discharge from the area where the ports have been put. If this happens, then you should immediately report to the doctor, because what has to be assessed whether it is an infection or if bile is leaking from any one of these sites, and then the doctor will take necessary action. Sometimes a swab is taken from this area and cultured to find out what kind of infection or bacteria is growing, and accordingly the antibiotic may have to be changed. There is one more type of infection which is very typical and unique about laparoscopic surgery, which is delayed onset of infection of the port area. The patient go back home, they are fine, they come back for follow-up, sometimes 3 weeks to even 3 months later, they come back with swelling and redness of the area of the port. They talk about some watery discharge coming. You take a swab and do culture, there is no bacteria is seen, and sometimes these go on, and none of the antibiotic helps it. And it has been studied that sometime in laparoscopic surgery, a typical infection called Mycobacterium cheluni. Now this is a same group of bacteria which also belong to Mycobacterium tuberculosis. So that's why when nothing else works, sometime anti-tuberculosis treatment help to control this type of infection. And if there is a tract or fistula formation, sometime excision of that infected area can help to cure this problem. Now comes the question, when the person can get back to normal activity. If the normal activity is at home, they probably wouldn't mind. But when can they go back to work? I've never seen anybody who wants to go back to work. Who wants? I mean, if you could just take rest for maybe 1 month, it would have been better. Now the question is, what's the ideal time? Usually after a laparoscopic gallbladder surgery, one should be able to go back within 5 to 7 days to work if the work does not involve a lot of physical activity. But in my experience of 26 years, I have seen all people who earn on a daily basis, like say lawyers, stockbrokers or surgeons, who earn according to the day of work, they all become fit. Surprisingly, people who actually have a fixed monthly salary, they tend to take a longer time to recover and get back to work. But if you really want to know what's the ideal, 5 to 7 days is good enough to get back to work. So today we discussed, if you are going for gallbladder surgery, the question that comes to your mind before surgery, what to expect after surgery. And if you have any questions in your mind, if you want to discuss anything, please write your comments, share it with your friends, subscribe to my channel, and keep watching such videos which are related to health and educational issues.